Thank you for the invitation to be here today. This is actually my first time in Santa Barbara. Here are my disclosures. The relevant disclosures to today's talk are I developed an outcome measure called the PRO-PD, Patient Reported Outcomes in Parkinson's Disease. And that is the only thing, a study that I'm recruiting for and an app that I built, but I don't make money on any of that. I do research at Bastyr University and University of Washington, and I work at Seattle Integrative Medicine. So to kick this off, I just want to say I am a naturopathic doctor, and in 2010, I got a government grant to leave practice and go into research. And as an outsider, I had not gone to conventional medical school. I did not do a neurology residency, and I was thrust into the world of Parkinson's disease. And my assignment was to find better ways to study lifestyle modification as a disease-modifying strategy. There are some times when the red pill and the blue pill, studies are more complicated than the red pill and the blue pill. You cannot have placebo exercise or placebo meditation. You cannot have a placebo early bedtime or late bedtime. And so we have to find ways to do research where the double-blind placebo-controlled trial doesn't cut it. And so that was my task. So when I came over to the world of Parkinson's and I had to figure out how to modify Parkinson's, what I realized very quickly is that we had no way to measure the rate of Parkinson's progression. We had no way to get to people during the first 10 to 20 years, and we had no way to slow the disease. So we were caught in this cycle where even if I said, hey, I think Brussels sprouts will slow Parkinson's, the response I got was, yeah, well, we won't know because we can't measure progression and we're getting to people so late, it probably won't make a meaningful difference. So I am thrilled to say that here we are 14 years later, and a lot has changed. As we just heard, there have been tremendous advances. We do have early screening tests are becoming more and more prevalent. More and more primary care providers are asking patients about acting out their dreams and loss of smell and constipation. We now have skin biopsy tests that are helping us get to patients a little bit earlier. We have dogs and all kinds of things we're working on ways to get to those people early, and then we're talking about what we're talking about here today. Where have we come as far as disease modification? What in terms of things that you can do today? I really agree with everything that we just heard. This is not a one thing causing one disease sort of situation. There are a whole bunch of straws on the camel's back that lead all of you to the same set of symptoms. This is really more of a syndrome than a disease. And so I think what we are going to see over the next 2 years is a major rebranding of what we call Parkinson's. I think we are going to start to talk about it more like a syndrome. We are going to start to recognize it more as a disease that is modifiable by lifestyle, and I think it's going to start being treated a lot more like type 2 diabetes than the way it has been treated. So my goals are pragmatic. I don't actually care why something works. I just want to know, does it work? And my definition of does it work is you tell me you feel better, right? So 1 million people, possibly as many as 2 million people, died of scurvy before we discovered that you could actually cure, treat, and prevent scurvy with limes. We used limes to completely eradicate scurvy for 200 years, as long as we have known about Parkinson's, before we discovered vitamin C. We live in a world right now where I could not get a Lyme study funded until I first discovered the vitamin C. And so I'm here to tell you, I want the mechanistic stuff. I want those other studies. I do want us to understand why things are happening, but I actually think we have tools that are effective that you could use right now, even if we don't understand why, that we are not employing. So for instance, this great study just came out a couple months ago showing that the more high-intensity exercise a person does, the more dopamine transmission they can see in the brain. it actually does look like we now have explanative research that says exercise increases dopamine. Fabulous, but they didn't really look at patient symptoms. That wasn't the point of the study. That's not what they were doing. They wanted to know, can we actually see proof of dopamine enhancement in the brain? As opposed to our study, which is called Pragmatic. What we see, the first 2 days of week of exercise don't count for much. Every day that you do 30 minutes of exercise, people who do 7 days a week of exercise are progressing slower than people who do 6. People who do 6 days of exercise are progressing slower than people who do 5. 5 is better than 4. 4 is better than 3. And the first 2 days don't actually seem to be associated with slower progression. So we all agree. I mean, we really do need both types of research. I just wanted to let you know that my loyalties and what I'm going to be talking to you about today is more the pragmatic end. The other thing, this has already been addressed, but I really do want to address this whole concept of getting to it late. By the time we get diagnosed, you've probably had it 10 to 20 years. You've heard about all these symptoms that are happening early. Most epidemiologic research that has been done is called traditional epidemiology. We study what things your children are doing throughout their life that may increase or decrease the risk of being diagnosed with Parkinson's. My research picks up the day of diagnosis and asks, is there something people are doing that is associated with the rate of progression? It's called clinical epidemiology, and that's the stuff I'm going to be talking about today. A couple other things I want to point out. A lot of people will come into my office saying, I'm doing all of this stuff for Parkinson's. And when I ask, well, what part of Parkinson's? I don't know, someone told me to do it because it was good for Parkinson's. And what I want to say is there are two different strategies, and they're very different. There is symptom management, in which case you should feel the benefit pretty quickly. If you are taking a therapy that improves your symptoms, you should feel better. As opposed to disease-modifying therapies, right? You might not go home, eat Brussels sprouts tonight, and feel better tomorrow, right? Even though it might turn out that vegetable intake is disease-modifying. And so these first couple years, it is really, really difficult for both you, the patient, and us, the researcher, to be able to distinguish whether a disease-modifying therapy really works. We don't want to do a 20-year study where it becomes very evident, but that's kind of what we're seeing. The longer you plan to live, the longer you live, the more valuable these disease-modifying therapies are. And you all want disease-modifying therapies. You want a way to slow the disease, and I just want to point out how difficult it is in these early years to feel or measure or see disease modification. As we've already talked about today, just because two things go together doesn't mean one caused the other. For example, in our data, I am about to tell you that beef and pork consumption are both associated with faster progression. But we can't tell if it's the beef or the pork or both because we can barely find any humans in our study who eat one but not the other. Right? Like people who eat beef also eat pork. We don't have enough people who only eat one to be able to differentiate. Is it both? Is it just, so that's an example of how difficult this can become. We are almost here. This is not real data, but this really is what it is starting to shape up to look like. What we have been doing is following 3,000 people over the last 10 years, and every 6 months we send them a survey and ask, who are you, how are you, and what are you doing? And what we do is we run code and we compare other people your age, your gender, and your income bracket diagnosed the same year as you. And we look to see, do the people just like you who eat cheeseburgers and take vitamin C and exercise do differently than the people who don't? So that's where we're talking. So because we did not have a questionnaire that accurately measured Parkinson's disease remotely, I needed to build one. And so I did a literature review of all the symptoms of Parkinson's. I spoke to hundreds of patients, and we came up with a list of about 35 symptoms that were commonly associated with Parkinson's. This is the ProPD. It's freely available. It's an app. It's online. And the surveys, the scale asks, on average, over the last 7 days, how severe have any of these symptoms been? If you've had really bad constipation, you slide it to the left. If it's not bad at all, you slide it to the right. It takes 3 to 5 minutes to get your score. We add up all the scores. And this is what the rate of Parkinson's progression looks like in North America. It's a little bit steeper than that in Sweden, interestingly. But what we see is people get about 10 good years. Right around year 10 is where people start to say their quality of life is going from good to fair. My personal goal is that patients with Parkinson's should be able to live until their 100th birthday, always staying below the blue zone. I want every day of the rest of your lives, your quality of life to be excellent, very good, or good. So we talked Mediterranean diet came up earlier today. Raise your hand if you think fish is on the Mediterranean diet. Raise your hand if you think bread is on the Mediterranean diet. Raise your hand if you think chicken is on the Mediterranean diet. Anyone know how many tablespoons of olive oil you need to eat per day to get a point for olive oil on the Mediterranean diet? 4. So the thing, even though we have these very popular diets that we have studied, the problem with them is that they are crude, and every one of you has a different picture in your head of what the Mediterranean diet means. And when you break down your concept and you compare it to the scale that researchers use to measure Mediterranean diet, they don't necessarily match up. Some researchers, I believe here in Southern California, came up with probably a better diet called the MIND diet. It was designed for Alzheimer's disease, but it's kind of a hodgepodge between the Mediterranean diet and some updated research. So these are 2 very popular and well-studied diets in Parkinson's. And what we did is we compared them using our study. How many points do you get on the Mediterranean diet? How many points do you get on the MIND diet? You can see there was a nice even spread. But the MIND diet was twice as effective as the Mediterranean diet for being associated with slower rates of Parkinson's progression. Okay. So what's on the MIND diet? And even more importantly, what symptoms are associated with improvement? The more any person with Parkinson's adhered to the MIND diet, the less urinary, sexual, and cognitive dysfunction they had, the less muscle pain they had, the better sleep they had, the fewer mood disorders, apathy, depression, and anxiety, and certainly the less constipation. Would anyone like help with any of these? So this is where it gets complicated. These are the foods recommended on the Mediterranean diet. These are the foods recommended on the MIND diet, and these are the ones that are the heavy hitters that seem to be really making an impact in Parkinson's. So my point here is that there is both some overlap, we are getting close, but neither of these diets is optimized for Parkinson's. If the Mediterranean diet did not include sofrito, it would be even better. If the MIND diet did not include poultry, it would be even better. So we are doing what we can to study diet and Parkinson's, but the diets that we're studying aren't great, and Parkinson's is hard to study. The variables in red are the only ones that are associated with slower Parkinson's progression. There are a whole bunch of things that are on the Mediterranean diet and the MIND diet that actually do not seem to be associated with better or worse Parkinson's anything. So what we decided to do is take a step back and ask a big picture question. It seems really common sense, but every one of these green dots is a real person with Parkinson's. And even though I told you that the average person gets 10 good years, you can see there are people who are in horrible shape a year or 2 after diagnosis, and there are people who are water skiing 21 years after diagnosis. I am trying to figure out what is the difference between these folks in these folks. And what we're about to talk about are, dietarily speaking, what is the difference? On your tables, you have the answer key. I just slipped you all the cliff notes, right? This is 10 years of my life's work on a coaster. So I want to apologize. I did make a promise to myself that I would not filter any of the information. I said publicly 8 years ago, if the data ends up that having a pet turtle is the secret to Parkinson's, I'm going to go with it. Right? Because we don't know. We don't know what we don't know. We don't know what we're missing. And my apology to all of you is, in a moment of weakness, I did not include wine on the good list because I was afraid you would all go home and try and drink your way to health. But if we're being honest, red wine is about as good for you as fruit, fresh fruit. So when I make my next version of the postcards, they will have wine on it. But we'll get to that in a minute. Okay, so very simply, these are the foods that are associated with slower rates of Parkinson's progression, as measured by patient-reported outcomes. The point system here is really important. What is really happening is I give people this list of foods, and they say, yeah, okay, she wants me to limit this and eat more of this, and they go home. And I don't think people really realize that fresh vegetables are 3 times better for you than olive oil, right? And I think when you really start to sit down and when we turn your diet into math, we can start to see that a person whose score is minus 400 is progressing half as quickly as a person whose score is minus 200. So you get out what you put in. This looks to be dose dependent. It's not good enough just to say eat your vegetables. I'm here to tell you somebody who eats 2 cups of vegetables a day in our data looks like they are progressing more slowly than a person who eats 1 cup of vegetables per day. So visually, I just want you to lay eyes on what real food looks like. Nuts, seeds, fruit. The MIND diet focuses on berries, whereas the Mediterranean diet says any fruit is fine. We don't know. Are berries better than bananas? Non-fried fish. I had an amazing seafood salad last night. I don't know. We only asked about non-fried fish. I get a lot of questions. What about oysters? What about shrimp? We don't know. We need more of you to enroll in the study. If you want more granular data, we need more participants. Fresh herbs, spices, coconut oil, olive oil, legumes, green tea, and red wine. So we don't know, is there something medicinal in these foods? Or is there really something in red wine? Or is it something about red wine drinkers? They're a little snootier, they've got a little more disposable income, they socialize a little bit more when they drink it. Maybe it has nothing to do with the wine, but the olfactory exposure. Dr. Bronstein was just talking about pesticides coming up the nose and causing insult. Why can't antioxidants come up the nose and cause protection? There really might be something like antioxidants, anthocyanins in the skin that we are releasing in grapes. This is when I started feeling bad about leaving it off the list. Because we really don't know, and I should not be the one filtering that. What I want to do is just be the messenger. I think what sets the diet and the foods that I'm talking to you about today aside off from the other diets, there are a lot of really smart people offering suggestions about what to eat. You know, we've got David Perlmutter, we've got Terry Walls, we've got all these neurologists suggesting diets. And I don't know that anyone's right or wrong, but they're all stemming from people's ideas and opinions. None of what I'm talking about here today is my opinion, right? This is just, I'm just the messenger. I surveyed 3,000 people with Parkinson's, and all we know is the more of these foods a person eats, the fewer symptoms they have. How many people are shocked to learn that the foods I just talked about are associated with slower Parkinson's progression? 5. Most of the time, the response I get is, duh. Right? This is the same list of foods that seems to protect against Alzheimer's, cancer, obesity, cardiovascular disease. Nothing here is that shocking, and I'm actually thrilled to see that that amount of congruence is naturally occurring in our literature. Where everybody starts disagreeing with me and kicking and screaming is when I start to talk about the foods that seem to be associated with faster disease progression. And what I want to say before I get into this list is I'll say again, it's not my opinion, and what you like, what your tongue enjoys, is very different than what may or may not be good for you. And we may have, as a society, normalized some things that might be really bad. And that is a more uncomfortable conversation. It's more inconvenient. It's difficult to address with your kids and your families, but it's the data. Same thing, we have numerical values, and we can see of all the foods that we've looked at, fruit from a can is the most strongly associated with Parkinson's progression. And again, this is all associations. We can't say causation, but at first I thought it was just people who were low income might be eating out of more cans, but we did our best to adjust for income. So let's just break these down a little bit. So the fruit from a can is a big one, because there actually is research going back 20 years that says that when you put acidic foods in cans, it leaches some of the metal out. So it could be the metals, it could be the lining, but here's where things start to get really complicated. They're called temporal associations. So in the past, it wasn't just fruit from a can, it was canned food in general, canned vegetables, even canned beans. But all of a sudden last year, canned vegetables and canned beans don't look like they are bad at all. So again, this type of data is not as clean as if you had a controlled trial. And it could be that there are just normal fluctuations in the data that we're getting. That's possible. But also in the last couple of years, they have phased bisphenol A out of the lining of a lot of cans. I mean, so it's really hard. It's not just me. It needs to be a team of researchers who's trying to make sense of how do we interpret these data. And I truly don't know if I should tell my patients to avoid canned vegetables or not. They were horrible last year and the year before. They weren't the year after. Dairy. This is where everyone's gloves come out. Okay. I cannot tell you how many times I've been paged. What about camel milk? I don't know. I don't know. We don't have enough people drinking camel milk in our data set to be able to tell you whether or not there is a loophole. People want to know about, well, my cheese is unpasteurized and mine is A2 cows, and everyone loves cheese. But here's the deal. We have decades of data. We have known for years the more dairy a person eats, the more likely they are to get Parkinson's. This is true for your children. Turn to the undiagnosed person next to you. This is the traditional epidemiology I'm talking about. We know, we have all these studies say the more dairy you consume, the more likely your diagnosis of Parkinson's. My frustration is if we have this much data, why aren't we using it? When has a primary care provider ever said you may want to chill out on the mammalian breast milk because it might increase your risk of Parkinson's? Why would we do all these studies if we're not going to do something with the results? Why are you still feeding your kids ice cream and cheese if we know that you want them to not get Parkinson's, but the data says that you're increasing the risk of Parkinson's? And this is where the conversation starts to get tough. We can see from every angle, we don't just ask, do you eat dairy, yes, no. We ask individual questions. All of the dairy products are associated with worse Parkinson's outcomes over time. Ice cream is clearly the worst, but ice cream, butter, cheese, yogurt, milk, butter. The more you eat, the more symptomatic a person with Parkinson's tends to be. Soda. No one's probably shocked to learn that soda is associated with worse outcomes. We don't know, is it the sugar-sweetened beverages? Maybe it's just taking up space that should have gone to that broccoli. Maybe it's not the soda, but the tin can or the plastic bottle it comes in. Fried foods, that's not really surprising, but where it gets hard is mechanism of action. We know that you can eat fried foods and change your microbiome. Maybe growing the wrong bugs is part of the problem. Or maybe it has nothing to do with the microbiome. Maybe we're just introducing a bunch of this chemical called acrylamide that has been shown to cause dopaminergic nerve damage. When you heat high carbohydrate foods up above 120 degrees, there is a neurotoxic chemical that gets made. The more toasted and browned, the more French fries and potato chips are all being consumed with your fried carbs. Someone crying? Bread and pasta. People want to know, what about gluten-free? But mine's sourdough, but I make mine at home with love. But I mill my own flour. I don't know. All I know is I am 95% confident that the patients in our study who are doing the worst eat more bread and pasta than the people who are doing the best. You all have to decide what to do with that data. Drinking from plastic bottles is associated with worse outcomes. These are just ideas I'm tossing out. I don't know if any of them are true. I'm just trying to provide some ideas for those of you. Sometimes if there's a reason for it, you stick to it a little bit better. Beef, chicken, and pork are associated with worse outcomes over time. Turkey is not. We have asked about turkey every step of the way, and turkey has never been associated with worse outcomes. Chicken has been every step of the way. Are they different birds? Are they farmed differently? Maybe nobody makes turkey nuggets. Maybe it's not about the food, but how the chicken is being prepared in a different way. When you eat turkey, it's sliced deli turkey. When you eat chicken, it's deep fried between bread. And so, again, this is all of the stuff that we have to unearth. I'm just going out casting a wide net. Frozen vegetables are associated with worse outcomes, but frozen fruit is not. I asked ChatGPT why that might be. And they told me a lot about two things came up that I did not know. Before you freeze vegetables, you blanch them. And because of the way that farming happens, there's more pesticide residue on vegetables. And so, again, I don't know if it's the pesticides or the blanching or the whatever, or my data's wrong. But what we do see is frozen vegetables, but not frozen fruit, associated with worse outcomes. Juice. The more juice a person eats, maybe it's the sugar, maybe it's the lack of fiber, maybe it's the plastic bottles it's coming in. No, I would not count it as juice. If you're juicing your own juice at home, I think that's fresh fruit. But again, this is where it gets complicated. There are a lot of different types of juices. So this is just a hodgepodge of these popular diets. This is our diet that we just talked about is the PRO diet, the MIND diet, the Mediterranean diet, and the ketogenic diet. And so even for those of you who are on the fence about this, you're not all in, you're not really sure about, do you really, really want to give up your ice cream? There are some things we all agree on, right? There isn't a study out there, a diet out there that doesn't suggest fresh fruits, fresh vegetables, nuts and seeds, olive oil aren't in your best interest. But it gets more complicated than just diet. So exercise, there are a lot of other variables that we are looking at besides food. What we see is that being poor and being lonely are the two greatest threats to Parkinson's disease progression. I had not appreciated how much financial insecurity was a threat to Parkinson's progression. Is it stress? Is it, I mean, look at the size of this word cloud is proportional to the impact. So people who say, I have trouble affording groceries, that's almost as bad for you as daily exercise is good for you. And for all of the work that we are doing in this amazing community, I don't see a lot of anything going into improving people's financial status. I mean, I don't have the answer. I mean, maybe we have, you know, these financial people come in and give lessons. Maybe we give people stipends. Maybe we deliver fresh food boxes to their house. But I don't believe we are going to, quote unquote, cure Parkinson's without addressing some of these harder conversations. Loneliness. People who say true to the statement, I am lonely, have more. Being lonely is as bad for you as 7 days a week of exercise is good for you. And along the loneliness lines, when I started this study, I did not think of being single as a risk factor for Parkinson's disease progression, but that is exactly what we are seeing. When your quality of life is poor, there is a 50-50 chance that you are partnered or single. But as quality of life goes up, by the time some people say, my quality of life is excellent, only 9% of people with Parkinson's who say my quality of life is excellent are single. It is really hard for a single person to find their way to excellent quality of life. I do not think the answer is to get all of you hitched. I think the answer is to figure out what is it about community and support networks that is so critical, and how can we make that more readily available. We can see that people who are lonely don't necessarily progress faster, they're just more symptomatic each step of the way, right? And that is this is how symptomatic a non-lonely person is, this is how symptomatic a lonely person is. And we can even tell you using that scale, the app, that we can even tell you which symptoms are more associated with loneliness. So, I would like you all to join a club and make a couple new friends. That's on the prescription pad here. And until somebody figures out why exercise and loneliness are associated with Parkinson's outcomes, my suggestion is you just make a friend and go exercise, right? And then along the lines of modifiable, this, again, now we're getting really complicated. This is a study looking at B12 levels among newly diagnosed people with Parkinson's disease. We'll just look at this first one because it's a little simpler. But what they did is they looked at a bunch of people early on with Parkinson's and measured their B12 levels. They did not give them B12, they just measured B12, stepped back, and watched. And what we are looking at here is your likelihood of being without dementia following diagnosis. So if your B12 level was less than 550, which is absolutely smack dab in the normal reference range, by the way, if your level was less than B12, less than 550, there was a 0% chance that they did not have dementia by year 10. However, if they were higher than 580, that was now down to a 75% chance that they were dementia-free by year 10. So is dementia a modifiable variable? Is B12 status a modifiable variable? How many of you know your B12 level? Why? If we have these data, and it's absolutely true, we have not yet done a study where we take all of these people with low B12, randomize half of them to fixing their B12, half of them to not fixing it, and see, can we actually change it? We have not done the study where we confidently know that if you take B12, we can prevent your dementia. We don't know. So all of you have to make a choice. You can wait for that study to be done, or you can ask your doc for a B12 level. Supplements, another tough conversation. Most of you, your head is spinning when it comes to supplements. 50% of what is sold over the counter does not even have in it what the label says it has in it. When you go to your doctor, a functional medicine doc, a naturopathic doc, half the time, you leave with $300 worth of supplements. There's huge profit margins sometimes going to the clinic. It's really hard to tell what's necessary, what's just in case, what's financially motivated. It gets confusing. So we have been, every year in the study, we ask people, what supplements have you been taking consistently over the last 6 months? And last year we published, there were about 12 supplements that were statistically significantly associated with better Parkinson's outcomes over time. This isn't a shopping list. They're all listed on your card. The ones in dark green are the ones that had more than 100 people reporting, even though ginkgo is at the top of the list, right? Out of the 1,100 people who responded to this survey, there were only 19 people taking ginkgo. That is not strong enough data for me to ask all my patients to start ginkgo. It just isn't. I mean, I get that it's statistically significant, but I also suspect those 19 people are doing a lot of other things too. I am not confident the reason those 19 people are doing so well is because of the ginkgo. But if I were designing a research study, these are certainly the products I'd be looking into. So there really is power in numbers. None of you, there's nobody in this room who's going to be able to tell if they are slowing their disease if they have cantaloupe for breakfast tomorrow morning and go do Tai Chi in the park in the afternoon. That's why we need to do research where we combine all of your data together. It's called big data, and there really is power in numbers. The more people who enroll in this study, the more granular the data, the more accurate the data that we can give you. For the first 7 years of this study, I just asked about wine, and every one of these talks, I didn't get 5 minutes in without red or white. It was the most common question I've ever gotten in 10 years, red or white? And the answer is red. We went back and we changed the questions a little bit, and white doesn't seem to be doing nearly as much as red. So if you all want to know more about, well, what about the sourdough, and what if my bread's gluten-free? And if you're interested in me expanding this data set so that you can explore the loopholes a little bit, please consider joining in this study. Let me just say something about the loopholes too. My personal philosophy is B+ is good enough. I mean, I really do think that quality of life matters, and it's not always about physical health. You have to take into account emotional health and spiritual health and financial health. And if, we have a rule, we don't bring the bad foods into our house, but we do, my kids do whatever they want when they're out and about. Right? The reason I behave at home is to afford myself a little bit of flexibility. If I'm in Italy, you better believe I'm eating gelato, right? But it's not going to be a Tuesday and Thursday night thing at home. So pick and choose your battles. I don't think any of this stuff has to be 100%, especially when we're in this fuzzy zone where we don't know what is or is not causative. We're just looking at associations. We have a huge North American bias. Almost all of the people in our study are from the United States and Canada, making it really difficult to extend these data and these findings globally. And for those of you who want to see where you fall on that chart, like I said, this app is called the Parkinson Symptom Tracking app. It's free on iOS and Android. You can download it, you can get your score, and you own your own data, you control it. Before you go see your doctor, you can print out this little one-page report that says, here's how I compare to my peers diagnosed the same time as me, here's how my symptoms have been changing, here's what's getting better, here's what's getting worse. So please use that, and thank you very much.